This episode is sponsored by Romanwell. Does your Google search contain something along the lines of, what can I eat with IBD? Are you stressing about how to navigate food choices at an upcoming wedding, family vacation, or graduation party? Don't worry. The IBD dietitians at Romanwell have got you covered. They're here to help you safely expand your diet and build your confidence in food selection by providing the one-on-one support and tools you need to navigate nutrition through all of life's phases. Go to romanwell.com to apply for a free consultation so you can start feeling and living well.
Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week, we talked to Dr. Tiffany Taft. Dr. Taft is the Research Associate Professor and Director of Psychogastroenterology Research at Northwestern University Feinberg School of Medicine. She's a licensed clinical psychologist who also happens to be living with Crohn's disease, and she is a leading expert on the psychological and social aspects of chronic digestive illnesses, including IBS, Crohn's disease, ulcerative colitis, and eosinophilic GI diseases. We talked to her about her research in medical trauma and post-traumatic stress. We talked to her about EOE and what is that. We talked to her about perceived stigma in inflammatory bowel disease. We talked to her about her Crohn's disease, and she gives great advice to some medical professionals on how to best work with patients to minimize trauma. And better yet, we learn how she likes to party. Cheers.
Hello, everyone. It's your co-host, Robin.
And it's your other co-host, Alicia. And I think this is going to be such a fun episode because we are joined by Dr. Tiffany Taft, and your name has already come up. And so you're semi-famous on our podcast already. So I'm very excited because our friend Josie, whose episode just dropped I think at this point, it'll be a couple of weeks ago. She works with you. She is one of your students. And so she connected us because I think she could tell how excited we were to talk to her. And I think we scared her maybe a little tiny bit. And she's like, please talk to my boss. So yay. Thank you for coming on. Yay, yay, yay.
Yes,
so we're going to start out by saying, what are you drinking?
I am drinking a Bell's Two-Hearted Ale, which is an IPA brewed in the great state of Michigan. One of my go-to favorite beers of all time.
Robin, what are you drinking?
I am drinking Prosecco.
Ooh, I love a sparkling.
So. I know you do. I'm channeling Alicia tonight.
I was going to drink a tequila cocktail in honor of Josie. And then I realized I have like no groceries in my house. And so it would have just been tequila. And I'm like, that's too far. So I'm actually drinking a Pinot Gris from New Zealand. Well, Tiffany, we are, as we mentioned, super excited to have you on. Can you tell us your connection to our IBD community, please?
Yeah, I come here wearing two hats. One as a patient, looking forward to my 20-year anniversary on May 13th of having Crohn's disease. And by, I think, a bit of sheer luck, or maybe the stars aligning, I got my first job at Northwestern University in Chicago as a research assistant during one of my appointments to my gastroenterologist that I was seeing at the time. I struck up a conversation with a different doctor. We had a shared interest in bicycling, and I was arguing with my doctor about how I needed to bike or I was going to go insane, and he wanted me to stop. And so we were kind of bickering even out into the hallway. And so he was like, oh, what kind of bike you have? Blah, 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 blah. And this was back when you had to print out your prescriptions and the printer was broken. So I think all the stars aligned to allow me to get offered a job doing research on irritable bowel syndrome. And that was in 2005. So a good 17 years ago now. So that is how I came to be at Northwestern. And then I was starting graduate school at the same time and working on my doctorate in clinical psychology and was planning to do some health stuff, but not necessarily GI, but I think the job and just how everything kind of fell into place, I landed in GI psychology, and that's where I've been since.
Very cool. I think it's really interesting that you didn't have Crohn's disease very long before you went into researching. So had you already decided to do psychology and then were diagnosed, or when were you diagnosed, sort of in between college, or tell us when exactly that happened?
Yeah, I was diagnosed in 2002. So I was 26. So I had graduated in 1997. I'm aging myself here. Okay. And my gap year turned into 7. Okay. And so I was working a corporate job that was very, very, very stressful, and got the first symptoms of Crohn's, so, the bleeding and what have you, 20 times in the bathroom at the office. That was fun.
Oh gosh.
And so I went to the doctor, and then took about 6 months, I think, maybe 9, to get a diagnosis and then to start treatment. So the getting sick propelled me to leave corporate world. I had been thinking about it every year. I was like, I should go back to school. I didn't plan to work in the corporate world. I have a degree in psychology in undergrad, but you can't do a lot with a bachelor's degree in psychology. So I did everything from baking bread to selling cigars to working for American Express. And then, Crohn's is really what made me go back to what I was supposed to be doing over that time.
Yeah. As somebody else with a bachelor's degree in psychology, no, it's a great degree to do a lot of things that are not psychology related, I found.
Mm-hmm.
So grad school is almost unnecessary. Sorry, psychology majors out there. So you said you started out with irritable bowel syndrome, but obviously our special interest is inflammatory bowel disease. I'm guessing it might be slightly close to your heart as well. And one of the things you really wanted to talk to us about that we started this conversation with Josie is about medical trauma in inflammatory bowel disease. And I am excited to hear you talk about this because you have several publications on this, and this is obviously special interest. So maybe give us a definition of medical trauma. I think most people probably know, but let's start there and then talk about what are you looking at when you're talking to people and doing this type of research?
Sure. This is something that I know Josie said has been researched a lot in other conditions, or like people who've been in the ICU. I'm sure we're going to see a bunch of it from our people who have had COVID. And when one of my colleagues at Northwestern, one of the IBD docs, came to me and said, hey, I'm noticing like PTSD kind of symptoms in my patients. I was like, let me go check the research, expecting it to have been done. And the only study that existed was out of Switzerland in Crohn's disease patients that found 90% of them had some form of symptoms of post-traumatic stress disorder. Not the full diagnostic, checking all the boxes.
That doesn't surprise me.
Wow, 90%.
That's
and so they saw that having the more PTSD type symptoms you had, the more likely you were to flare. Like they did some really cool stuff looking at that. So I was floored that nothing existed in the United States. But then I took a pause and I thought, maybe I'm not as surprised. But initially it was very shocking because medical trauma is such a real and pervasive issue. And I think a disease like IBD brings a lot of different opportunities, experiences that can be traumatic. And so we really started looking at that in more detail, starting out with a smaller study of about 140 people. And we gave a questionnaire that is used to diagnose as much as you can through a questionnaire, post-traumatic stress disorder. It's like what the Department of Veterans Affairs uses and things like that. And we gave it to about 140 people, and it came back like 25, 30% of folks met what I would say moderate to severe symptoms of post-traumatic stress. I was like, that can't be real. So we went and asked for some money. So that first study we just kind of did on our own. And then I got a lovely grant from the Digestive Health Foundation, which is a philanthropic group affiliated with Northwestern. And then we surveyed around 1,000 people and we replicated those numbers. And I was like, oh shit. This is real. It wasn't a fluke. And I think, I can confidently say that roughly 25 to 30% of patients have moderate to severe post-traumatic stress symptoms. And then that number is even higher in non-white racial and ethnic minorities. Hispanic participants were close to 50% for some of the different symptoms that you can have. So I just got another grant from the Digestive Health Foundation, and we are going to specifically look at patients of African American, Black, Latino, Hispanic descent to see if those numbers are real. And I really, really hope those are wrong. So we'll be putting that out next year, hopefully.
Yikes. Gosh, I hope you're right that it's wrong, but my gut tells me it's not. I don't,
Yeah.
and when I was reading your research, it was like all of these groups, and it was basically the only people that weren't in the higher percentage were like white men.
Correct. Yep. Mm-hmm.
Educated white men. I'm like, God damn it, you educated white men. Why is like everything easier for you? And yet you never know.
Mm-hmm.
Sorry. different soapbox, different day. That is really, really fascinating. And I am excited that you're going to be doing that research because I do feel like it's obviously so very, very necessary. I am curious because this reminded me of a conversation that when we talked to Ashish Patel, who's a pediatric IBD doctor, we talked about consent, and we talked about how do you teach kids about consent, especially when you're dealing with an area of the body that is obviously a lot of people consider that a very private area of the body, myself included. But when we're talking about these other diseases, obviously they're not talking about things that are like a very private area of the body. Like the other research that's been done is on cancer and HIV and things like that. So I guess there was a part of me that was wondering, is there something about the type of disease it is, the area of the body that we're talking about that contributes to PTS, that lack of consent potentially happens in a hospital situation where things are done to you because they have to be done to you? Or what do you think it is? I realize that's a really hard question to ask you. Like, why don't you solve this for me right now, Tiffany?
Let me take a sip of my beer before.
Right? Yeah. I feel like you might need it.
Tackling that one.
Only the easy questions today.
Yeah.
Only the easy ones.
Sorry.
No, it's a very important question. And I don't have any research to back this up, but I would love to do this level of detailed understanding, right? We're really good at kind of scratching the surface of things, but I'd like to do some more deeper dives into exactly what is going on. So we do have some understanding of what is it about IBD that makes it more likely to cause medical trauma, and hospitalizations by far came to be a main source. So we did some interviews with about 19 patients with IBD, and some had PTSD. We interviewed them, so I diagnosed them with PTSD, or they knew that they had it, or they didn't. They were on the lower end, but they still had some symptoms and had at least had a traumatic experience. Fun fact, in our paper that we're working on that Josie mentioned that's under review, the average number of traumatic events IBD patients report is about 2 to 3 on average, whether it's related to a hospital stay, disease symptoms, treatments, procedures. So people are experiencing not just like a single event, it's multiple. And I think that is one of the things about IBD, right? Yeah. You're going for, I think sometimes because it's 20 years, how many hoses have been placed places that hoses shouldn't be placed? And, I have fistulizing disease. How many people have been in places that I'm just like, okay, sure. And like you said, you're kind of like, and I'm an adult, and I'm sitting there like, I really don't want you in there. ER physician, no offense, that I don't know. And so I can only imagine as a child, or a teenager, the parents giving consent. And so the child having to endure, I could see really setting the stage if that doesn't become trauma then, the next time you're going to be on edge, right? Of course. I mean, why wouldn't you be? And the more that happens over and over again, and I think because of the nature of IBD, we're asked to do so much that I think sometimes we just kind of do and don't really pause to think about like, wow, that's been a lot of stuff that I've had to do. And the more severe your disease is, the more intense that can be.
Yeah, it definitely makes sense because it is so many procedures that go along with, having inflammatory bowel disease. And I think about even having, again, just listen to Josie's episode, her talking about the shortest amount of time between surgery being 11 days, like that, that's so many surgeries. It's such a short amount of time. It's so many things that happen. And initially when you said 2 episodes, I was like, that doesn't seem that bad. And then I think about the fact that 2 episodes of very, very traumatic things is really bad. 1 episode is bad, So.
I wonder how many, as someone also 22 years, I wonder how many, underreporting. They're just saying the worst, these are the ones that were the worst that I can't let go of or get over because in 22 years, I probably would only say, a handful, couple, 2, 3 were traumatic because they still affect me today. But there's so many that would contribute to the fact that those 2 or 3 are as traumatic as they are. So
I think to go back to your question about IBD, that is one piece. And then I think there are some certain things that came out of our interviews that were particularly bad, and nasogastric tube placement. And I'm trying not to get too detailed. I don't want to like set people off, trigger people, but nasogastric tube placement. And I had to watch my friend get one. So my friend has Crohn's and had a bowel obstruction, and she started to throw up, things that you shouldn't throw up. And she was in the hospital. She had just had temporary ileostomy surgery. And I looked in the thing and I'm like, oh no. And they came in with the tube. And I remember taking her hands and just saying, Emily, this is going to fucking suck. Look at me, breathe. And if I hadn't been there, I don't know that the resident or the fellow or whoever the guy was that put the tube in, the nurse, the people that were standing around would have said a word to her. I've been fortunate to not have gone through that, but I just was thinking, Jesus, what if I wasn't there to like hold her hands and prepare her and talk her through it? And so that came out in our interviews over and over again as one of the contributing factors of trauma from hospitalizations. The other part of it, is communication. That was the other main piece. So what was, again, came up in our interviews was you're in the hospital, you're sick, you're not feeling super great. And then the team comes by and maybe the colorectal surgeon comes by and nobody had really mentioned that you were going to have surgery to you. And there's this like drive-by aspect. I work in an academic hospital. So it's like 27 people come in, and and then they're out. Right. And so people would just kind of freeze and be like, wait, what? You're going to do what? We're going to have an ileostomy, or whatever. And they just go, mm-hmm. And then what they would do is they would get on their phone or their tablet and go on Dr. Google to try and fill in the information that was missing, either that they were too terrified to ask about, or the surgeon was just kind of nonchalant about it because that's his job or her job. And they just kind of that's what I do. But the individual sitting there was like freaking out going on Dr. Google, and we've all been on Dr. Google. And so someone said in the interviews, they should block Google in the hospital. So you can't go like Mayo Clinic, all those websites,
Yes. I agree with that. Yes.
Block it because you get into these holes. Yeah.
I say, put your hands up and step away from the Google.
Yeah.
Well, and I think you're right. I mean, and this happens in any hospital setting, not just academic settings, but that idea that somebody else has had the conversation with them. I would imagine that isn't maybe documented in the chart of like, we took this step to make sure we let the patient know exactly what was going on, because there's so many people coming in and out of the room and touching, not metaphorically touching that patient. It's very easy to say, well, I'm sure somebody else explained this to them and it didn't get explained. And then all of a sudden you're like, wait, surgery? Pardon me? What's happening?
Yeah. I mean, I'm from Chicago, so Midwestern nice. And I've thrown people out of the room in just outpatient visits. I had who's a resident or a fellow routine visit with my gastroenterologist, who I know very well, have a good relationship with. But we had some delicate topics to talk about, rectovaginal fistula. And this dude was sitting there on his phone, like just doing whatever. And I just looked over at him and I was like, he can leave now. And she threw him out. So I'm
applauding you. Good job.
Yeah, you can overcome that Midwestern nice. It's hard, but with practice, you can kick people out.
Right. Because I would have been like, are you tweeting this? Get off your phone, asshole.
Right. I'm like, what could you possibly have to be doing right now? Yeah, who knows what he was probably reading email or maybe looking at Reddit, who knows? But yeah. Well,
let's give him the benefit of that and assume he was looking up retrovaginal fistulas and educating himself. Let's go with that.
We'll go.
I mean, there is hope, right? There's hope. Right. That's what he's doing.
Mm-hmm.
Absolutely. Before we step away from trauma and PTS, is there anything else that I asked you that you didn't get to yet? Because I felt like I gave you like a very, very, very huge question.
Yeah, you asked about treatment.
Oh, yeah.
And so, yes, we are looking at part of that grant that we just got that's going to survey people of underrepresented minority groups. We're also doing a small treatment trial of a validated treatment that the VA uses. So there's a lot of PTSD in the VA, right, with our combat veterans. Yeah. And so a lot of the research comes out of there. And so we're going to trial that in a small number of people who recently were discharged from the hospital to see if we can prevent PTSD development as a means to not try and like put out the fire later. So a lot of what I do is very reactive. Mm-hmm. People don't end up in our offices until things are bad.
Yeah.
And just like you don't want to roll up to your doctor when things are really bad, the same principles apply to mental health. But as we know, that doesn't happen. So there are treatments, but they have to be done by somebody who knows what they're doing. And while I spent a year at the VA and I know these treatments, I am not a trauma therapist. So I have undergone additional training and things like that. So just because you have a degree and you're in social work, right? Unless you do extra training, trauma work can be risky in the hands of somebody who doesn't know what they're doing.
Yes.
And so I say to my physician friends, if you're listening, if you have a patient with PTSD symptoms, so nightmares, flashbacks, feeling keyed up on edge, low mood, irritability, difficulty sleeping, avoidance behaviors, so like not showing up to appointments a lot. If you suspect that, you really need to find a trauma therapist. So it can't be just anybody. So it takes a little bit of work to find that person. And then there are treatments that can be used that are highly effective, but also very difficult to do, because what we do is we ask the person to tell us their story or write it down. There's different ways, that we do it. So for people who don't have access to therapists, because mental health in this country is interesting. And with COVID, it's really gotten worse.
Yes.
There are a couple of things that I could suggest. There is a free app from the VA called PTSD Coach. Ooh. It's not flashy. It's not, super interactive. It's free. And you can use that to work through some modules, learn some skills like grounding and other things. You're not going to do like a full treatment with that. But for somebody who's like, I'd like to try to look at some of this, I feel like I can, that's a great app. And then the other piece of that is looking at reliable resources online. I don't want to rattle off a bunch, but I can send some. I saw in your podcast notes, you had some links to stuff. So I can send some links for people to take a look at.
Oh, great.
Learning some relaxation skills, but like meditation, no, not so much, because a lot of people find meditation, if you have PTSD, to be difficult because all the intrusive thoughts start coming in. So there's other things that we have people do. So there are treatments, even things that you can do if you can't access mental health easily for all the barriers that we have in the US. So I'll be sure to give you guys resources for that.
Thank you. You're right. COVID unfortunately has created a shortage of therapy for folks because so many people are struggling because of the pandemic. So it has become a little harder for people to access, but also just, in general, mental health is not always covered by insurance and things like that. And so it just makes it a resource that not everybody is able to do. So I was at a conference, this is a couple of years ago now, but they were looking at utilizing virtual reality as a way to help with some of this, especially in the hospitals. So I'm curious what you know about that.
I am sort of familiar with that. They were actually starting to pilot VR at the VA when I was there in 2008. So it's been around, it's been looked at as a means to help people work through their trauma. I think it's an option and it can be helpful to have some of the visual and more immersive experiences to help work through trauma. I don't know how you access that. Outside of the VA, I don't know if you saw or they said in the talk, like, where would I go to find somebody who uses VR?
Yeah, it had been used more for pain control in the one that I had, the conference that I had attended, because and it was very effective there. And I've also heard it used in addiction resources and addiction treatment for people to kind of be in a system, be in a place that would be triggering to them. And therefore, and again, I'm guessing that's what they use it for, like combat situations as well. So, but I was curious about that because it's, it's one of these like mind over matter kind of situations, like you're in the VR situation and all of a sudden it shifts your perspective, it shifts your brain in a really unique way. Sorry.
Yeah, it would definitely help with like that exposure part of trauma therapy. So one of the things we ask people do is to go to places that are triggering, approach it versus avoid it. And so for VR, for medical trauma, we might, instead of having you actually go to the hospital, we might have a hospital room, might have some beeping and replicate some of the environment, even the smells. I know we don't have smell technology yet with VR, but smell is one of the most triggering senses for trauma.
That is interesting to me. I wonder, my last couple of surgeries were very traumatic, but when I went to the local hospital to have my iron infusion, that didn't bother me the same way. I was still going to a hospital, still getting an IV, but it wasn't, even when I had my last scope, I was getting, tears streaming, chest getting tight before they
give me the propofol, which, best nap makes all the prep worth it. But I wonder if smell has something to do with that, because it was a much smaller, like, community hospital. Surgeries were not happening there. Like, real emergencies were not happening there. It was more like a doctor's office room. So I wonder if that has something to do with it.
Yeah, I think people will be like, I don't even know where the trigger came from, and if that's happening, it was probably a smell.
Very interesting.
I know for addiction, that's what they're doing too, is like you said, they put the VR goggles on, they're in a place that's triggering, but then they'll kind of put in some of those smells so that they can try to work through that as well. Because you'd imagine if you're in a situation, for instance, with an alcohol addiction and you're smelling alcohol, that's going to be a huge trigger for you. And so obviously they figured this out with addiction treatment. Sorry, different topic, different day. One thing I thought was super interesting, staying on this PTS line, is in one paper that you had, there was a connection between your microbiome and PTS. So can you tell us a little bit about that?
Yes. So this is a new area. Microbiome is hot right now, right? All the guys who play with mice and things are really into this topic, which is great. I'm poking fun, but they're doing important stuff, right? So it is interesting that we have found and just are looking at research to date that, so in IBD, the microbiome, the bacteria, viruses, fungi are different than in a healthy person or someone without IBD. So we know that that's been established by our friends doing that research. And we were looking at, what does the microbiome of someone with PTSD look like? And there's not a ton, but there's a handful of studies in people and then super stressed out mice, which I feel so bad for these mice. And some of these studies I read, I'm like, that the microbiome of PTSD folks looks very similar to people with IBD. There are a lot of overlapping, like things that are too much that you shouldn't have and too little of you should have. I can't start rattling off lactobacillus and what have you. So we thought that was really interesting. And we're like, does the microbiome matter here? And that doesn't make people with IBD more susceptible to developing PTSD? Or is it a down from the brain to the gut chronic stress affecting the microbiome? And we think it's both. So we are looking to get some money from the government or somebody, because this stuff's expensive to do. Microbiome research costs a lot of money. And so we want to look at that. One of my colleagues over at the University of Illinois at Chicago is like a microbiome expert. And she's like, I think there's something here, but we can't say for sure. But that whole brain gut axis, there's a whole piece of immunology to that doesn't get talked about. And so there's a whole field called psychoneuroimmunology. Say that fast after having your drinks, right?
One more sip of beer. You can do it.
So it's been around for 40 years and they look at this stuff in other disease states, not IBD so much. And there's something there, cytokines, inflammatory markers, estrogens, progesterones are implicated. So us ladies might be more susceptible because of our hormonal things. The metabolome, which is a whole other part of the gut, there's a lot of overlap. It was really interesting to do that. And so I think that this is something that will be a thing. It's just a matter of when and whoever wants to do this research, please do it.
So, attention, calling all researchers.
Yep. I think
calling all funders.
Exactly. Can we have some money? And yeah, I think in the next, I hate to say 10 years, because that sounds like a long time, but this stuff is so slow. Yeah. And so I would say in the next 10 years, there probably will be a lot more information about this type of stuff.
I think it's super interesting. You were saying that the psychoneuroimmunology has been around for so long, because I know, having a parent who had multiple sclerosis, that MS and your gut microbiome connection is a pretty recent research area for them. Also, microbiome research in IBD I'm sure people have been doing it for a long time, but it's, like you said, it's just become this very hot topic in the last, 5 years, it feels like?
Yeah, I would say 5 years. I mean, I have a theory about that.
We'd love to hear it. We love theories.
This is my experience as a psychologist working in the medical world. Until a physician finds it and says that it's a thing, psychoneuroimmunology is dominated by psychologists and physiologists. And so until the physician who has the authority and the respect, which great, goes, you know what, that's probably important. That's when it becomes important. And that's all I'll say about that.
Yeah. Chances are there was an educated middle-aged white man would be my guess. Probably usually also goes along with that.
Correct. So there may be research in Africa or, places that don't typically get the credit. And a lot of this research is done not in the United States.
Yeah.
That is true. So there's that. So there are forces at play, unfortunately, that I think have prevented the psychoneuroimmunology piece to get truly brought into IBD because it was a psychologist's idea and not necessarily a IBD physician's idea.
Well, what we will say is that it has been recognized now, no matter who was the person to recognize this, it's recognized now and it's becoming better funded and better researched. And so
that's all that matters at the end of the day.
Cheers to that. So we're going to cheers to that.
This episode is sponsored by Well. Have you ever felt overwhelmed and unsure about what questions you should ask your doctor or if you should get a referral to a dietitian? If so, you are not alone. The dietitians over at Well help patients every day navigate these questions and many more. They've just released an amazing free resource for patients called the IBD Patient Starter Kit that is jam-packed with tips and tools to empower you to become your own best advocate. Check out the show notes or head on over to RomanWell.com to download a copy of the IBD Patient Starter Kit today.
I want to go down a slightly different path here. One of the other things you wrote to us and said that it was important to you is the relationship between food and people with IBD and how that shifts probably even before they're diagnosed, but definitely after the diagnosis. So tell us why this is of interest to you and why you want to talk to us about this, because I think we want to talk about it.
Yes, we talk to as many people as we can about it.
Yeah, it's another hot topic, right? So we got microbiome, and then we have something called ARFID, avoidant restrictive food intake disorder.
Yes, Josie introduced us to this, so thank you.
Yeah, I heard her bring that up. So ARFID is a diagnosis in the psychiatric DSM-5 that was developed for children who are picky eaters or have sensory concerns, like don't ask me to eat anything squishy or what have you, not really interested in food. And then there's this random 4 questions, I think, about fear of consequences, and it's all related to digestive symptoms. So ARFID is a pediatric diagnosis. It is not validated in adults. It is certainly not validated in adults with digestive diseases. So this is a little bit of a crusade that I'm on. And are there people with IBD and other digestive conditions that meet what we would call the criteria for ARFID? Absolutely. I've worked with them. Yeah. My fear is that normal reactions to pain, diarrhea, nausea, whatever else are being pathologized because it's what the clarifier is behaviors that are deemed to be excessive or more than what would be considered reasonable. And my question is by whom? Because if you have the stomach flu, what are you doing when you have the stomach flu? You're maybe eating toast. Right. Having some Sprite or whatever, like you're not eating and nobody would ask you to eat. So why are we putting that expectation on people who are experiencing the same type of symptoms, but chronically? Sure, eating toast for the long term is not a viable solution, but I really worry about pathologizing this. So I wanted people to be really careful in thinking about ARFID and who we say has it, and then what we say is reasonable, but still unhealthy. And we want to help people get to a healthier diet and feel safer with eating when they're not feeling well.
That's an important distinction to make between, not sort of shaming people about what they're eating or, like you said, pathologizing it and turning it into a diagnosis, but also recognizing when that behavior does transition over into problematic behavior. Like, now you're feeling better, but you're still only eating toast. And so, or your disease is well controlled and you're still only eating toast and Sprite, then at that point, what do we do to intervene with that person to help them not be afraid to try different things and be afraid to try different, like bring more into your diet? I think but that feels like, this feels like this is IBD, is this delicate balance of like, how do we support people without making them another diagnosis?
Alicia, it makes me think about the year that I ate white rice and grilled chicken. And, I might add a squeeze of lime or a squeeze of lemon if I was feeling like, frisky. So, it was almost a whole year that I did that, but that's when I was in the worst flare and my doctor wasn't like they kept running tests, but weren't changing my diagnosis from ulcerative colitis to Crohn's, which eventually that did happen when I changed to a specialist. But I legitimately just ate that rice, grilled chicken, bananas, toast.
You've thrown an avocado, I think, every once in a while too.
Oh yeah, I did do that.
So that to me what is that? Is that healthy? No, it's not the best diet, right? And I'm sure how'd you feel when we're not going to start a therapy session, I promise.
No,
but
it's fine. It's fine. It's fine.
How was that for you to eat like that for a year? I think that's a question that doesn't get asked. People
really
just
does.
Look at it like, that's weird. Why would you do that? Right. It's like, how about, what was that like for you?
Right. I mean, it wasn't my preferred dietary choices, but also, I mean, I was avoiding pain. If we're avoiding something, I was avoiding pain. I was in excruciating pain most of the time. And those were the foods that I could eat that were the least painful to digest. Mm-hmm. Right. So if I tried to add something else to it and it was painful, back to my rice and plain grilled chicken. So
I guess I just think about and I knew you during that time. And so I remember you being frustrated. I remember looking at your face as you were eating what I was not eating and you being frustrated. The other thing I think about is, as you were talking about that, how helpless and hopeless that must have felt, because you didn't know if what you were going to put in your mouth was going to hurt you. And there was so little that didn't hurt you that it's and you weren't getting answers. What a kind of bad place to be. I'm sorry. I hope I'm not re-traumatizing you. Speaking of trauma, Robin, let's talk about how traumatic your year was. Let's talk about your surgery while we're at it and how shitty that went too.
But we do have Dr. Taft on the line. So
yes.
I mean,
No,
let's go.
Just that helpless and hopeless feeling, and about how insidious that feels when that's your reality for a long time.
Yes. I mean, and I got told a lot too, well, why don't you just keep a food journal? So, I mean, okay. I love that smile. Thank you, Dr. Taft.
Yeah.
I just, in 22 years, how many times I've been told to keep a food journal, right? I feel like it's fine.
Yeah.
That's fine.
Robin has a therapist.
Yes, I do. I'm in therapy. Yes.
Good. I think rice and chicken and white foods, I don't know what it is about them. I'm not a dietitian. Maybe I can connect you with some of our dietitian experts if you want someone like that on your podcast. Just keep passing the baton around. Yeah. There's something, those are the foods people go to. Those are the foods I hear over and over again. White rice, and white rice is binding, right? So it helps you slow down the express train that's going on in your colon. Chickens, for some reason, feels more soothing. Toast. So these white carbohydrate-y foods are what people turn to all the time. It's interesting. And the idea of even adding in something that shouldn't hurt, and you've even tried it, you're trying. So keeping food journals, we're kind of poking fun at. It can be helpful once, but
the first time,
not
the first
repeatedly.
time.
Yeah. To try and get a sense of, understand how you're eating and all that good stuff. Absolutely. But 20 years into, no, we don't need to be doing food journals. So
no, thank you. Thank you for that confirmation. I'm taking that with me. I'm keeping it in my pocket.
Bless their hearts, as they say in Texas. Yes. Can I ask you, I've heard this as a co-diagnosis for a lot of people with IBD. So EOE, what the heck is that? And is it a common co-diagnosis with IBD?
Yeah, I have EOE too. So
hence why I looked it up.
So eosinophilic esophagitis is more like a allergic E type of thing. It's an immune mediated disease like IBD is, but we're talking about different parts, but also some overlap in certain things that in the immune system that are overactive, etc. So in your esophagus, there should be no eosinophils. So an eosinophil is a type of white blood cell, and they are in other parts of your digestive system, but the esophagus should have 0. So in people who have EOE, the eosinophils show up to party when you eat foods that are triggers. And the most common foods that are triggers of EOE are wheat, dairy, soy, eggs, nuts, peanuts, tree nuts, fish, shellfish. I think that's all of them.
I mean, that's just one or two.
That's a lot
of
allergens.
Everything, right?
Yeah. But it feels like those are the foods that I hear a lot of people having very significant allergies to.
Yeah. So all the more common food allergens are the EOE top 8. And so when all the eosinophils, so I have EOE, one of my triggers is wheat and soy. So nothing has wheat or soy in it prepackaged in the United States. So should I eat some Triscuits or something because I'm feeling daring, the eosinophils will show up and
because you like to party.
Infiltrate. I do. I party with Triscuits. So I told you I'm old. So they come, and when they're there, they cause inflammation and damage. And so what the esophagus does, it's supposed to be kind of flexible and pliable and all that good stuff. It starts to get stenotic or stenosis and like stiff. And so, or narrowing, you get like strictures. I can get strictures in IBD, right? And so what happens is the food goes down real slow, or it even gets stuck, something called an impaction. And that's a medical emergency if you can't clear it. By clearing it, I mean, go lean over a toilet and throw it up. So that's a coping mechanism that people develop with EOE. There aren't really great treatments for it. There are dietary elimination, which I have done, and it's not fun, and swallowed topical steroids. So something that you would get for like a nebulizer for asthma, the liquid budesonide, you put it in something like honey or something viscous, and you drink it and it kind of slides down and coats. That's it. There is a biologic coming out soon, but as someone who is already on a biologic for Crohn's disease that is working very well, how am I going to take 2 biologics from a safety? I know it's a thing. I know that people do take 2 biologics, but it makes me a little twitchy, even though I know this stuff. And then my insurance is going to be like, I'm sorry, what? So it becomes really complicated. And they are seeing, unfortunately, more people with IBD developing EOE. IBD tends to predate EOE. So there's something going on. They're actually keeping a database of people at Northwestern who had IBD and have gone on to develop EOE. It's got hundreds of people in it at this point, which isn't a ton, but it's definitely something that they've noticed, and they're kind of going, why is this a thing? Celiac disease is also a comorbidity in EOE and IBD as well. So you could have the trifecta, which I think is incredibly rare. So I think people either get celiac or EOE, or 2 of the 3. I think getting all 3 is pretty rare at this point.
I'm going to be honest. It really doesn't sound like a party to me. I mean,
even with Triscuits,
even with the Triscuits, I'm not feeling the party aspect of this.
Yeah, it's different than Crohn's. It feels easier to manage in some ways, and it's less painful. Like Crohn's, it just sits there, right? And you just feel pain a lot, and doesn't matter what you do. EOE is more, I'm eating the things I shouldn't be eating. I'm causing some inflammation. I've only had a couple of food impactions, in the time I've had EOE, and I was able to manage them without having to go to like a emergency room. So it's not a fun disease by any stretch. People who have it struggle. A lot of kids are diagnosed with it. Boys more often than girls for some reason. And so in children, it can be particularly difficult. I think because I developed it after my first pregnancy and I knew what it was. Maybe that's why I can call it a party with Triscuits, or other people probably, right, would have a reaction similar to yours.
Wow. Is it more common in people with Crohn's disease? Because Crohn's disease can affect for like more, I mean, ulcerative colitis is obviously your colon, but Crohn's can affect any part from mouth, like gum to bum, as they say in the pediatric world.
I want to say yes. I do know that there are certainly people with ulcerative colitis that have EOE, but I want to say that, the Crohn's patients are more likely to get it than the UC folks.
Yeah, but you're right. We rail against the insurance companies a bit on this podcast, but I was like, gosh, even if they come out with a medication and it's a biologic, your insurance companies can be like, why don't you try these other biologics first? Okay, that'd be great.
Or don't. Why don't you just not eat Triscuits? That's a heck of a lot cheaper.
I mean, but they're Triscuits.
Biologic. I mean, you can get a lot of Triscuits for $10,000.
This is true.
That's a lot of Triscuits. In fact, if you eat that many Triscuits, there's probably a whole different eating disorder you have that goes along with that one. Binge eating disorder, maybe? Don't know about that one. Your previous research, you were looking at perceived stigma. What did you find with your research? Did people with IBD feel like there was more stigma attached to their disease? Was it versus other diseases? Tell me about that research.
Yeah, so I've done a few. My doctoral dissertation was on stigma in IBD, and yes, the short answer is yes, people do perceive others hold negative stereotypes. They get passed over maybe at work for things. So there's definitely a perception of stigma, which is basically identifying somebody as other, there's something wrong with them. I don't want to associate with them. And so, yes, people with IBD report that. They also report we're internalizing that stigma, which is more of a problem than just perceiving it. In that not only do I think or hear or perceive that people are saying these really shitty things about me, I'm starting to believe them. I call it believing the bullshit, in that it's not like, oh no, I'm going to resist that. So some people resist it actively and they're like, but other folks, it starts to get in there and mess with how they see themselves. And that is the most detrimental by far in terms of like outcomes, depression, anxiety, etc. And so that's when we worry about more. But obviously we don't want people perceiving that other people are being, jerks, being nice, towards them because they have IBD. We did compare them to irritable bowel syndrome in one study, and people with IBS are more stigmatized or perceive more stigma because of the whole, well, it's not real, it's all in your head, narrative that has been going on forever for IBS. My first research at Northwestern was in stigma and IBS. And yeah, so they have all the bowel taboo and the symptoms and the diarrhea and all that IBD has, but IBD is a real disease where IBS is not. And it's like, cool, And so IBS patients have been really, really burdened by stigma. And I think there's a pushback now of like, no, I've seen people with IBS who are sicker than people with IBD because the person with IBD has treatment options, right? And if they work quite well. What does IBS have? It's all symptom-driven treatment. And so it's not a matter of, is the colon super inflamed and looks like a disaster? It's how symptomatic are they? And the symptoms are very similar. And so I think it's a real problem, and it actually starts in medical school, and it's kind of passed down by people who are, physicians are a source of stigma, much more so towards IBS. But some patients with IBD report that too, mostly when they're coming in with pain or like fatigue. So the bowel stuff, great, fine. We'll talk about that, no problem. But if your pain management or your fatigue is kicking and you should be fine, that's when IBD patients start to report feeling more stigmatized by healthcare professionals.
I mean, that tracks with a lot of other diseases too. I mean, you think of people who have chronic pain syndromes or fibromyalgia or things like that, that really don't feel heard, or, it just reminds me of that, where the medical community seems to poo-poo it and go, oh, they're just drug seeking, or they're women.
Mm-hmm. Mostly, right. Yeah. Mm-hmm. Right. Hysterical, wandering uterus.
That's right.
Right. Oh my God. Yes.
That's right.
That's my favorite medical history thing ever. The wandering uterus.
Wandering uterus.
Yeah, it is unfortunately female dominated illnesses definitely get more stigma as well. It's really not good.
I'm curious, did the age of diagnosis matter as it related to perceived stigma? So like people, I'm thinking of Caroline, our guest, who doesn't remember her life pre-diagnosis. Like she's just sort of always had it. So in her case, is she more resilient to that self-talk because she's just always, this has just been part of her personality growing up on all, versus somebody who's diagnosed later in life who thought they were somebody different and now has to shift their thoughts about themselves based on this new diagnosis?
Yeah, I think the people who are diagnosed young and don't really know life much without it we didn't study that, that young. Mm-hmm. Everyone was adults in our research, and I don't think many of them were in that super kind of younger group. We definitely saw improvement with stigma or perception of stigma with longer duration. So the longer you have IBD, the less stigma you tend to perceive and internalize. The bad or the not so great thing that we found was remission status doesn't seem to matter. So people who, even if they're in remission, they're not having those symptoms that are taboo, they still feel the same levels of stigma. So perception of stigma does not go down with remission. So that's unfortunate. So something we just have to be paying attention to no matter how well or not well the person is feeling. And then, people who are older, so whether they've had IBD a really long time, or I know that some people get diagnosed older in life, they also reported less stigma perception. I think there is this experience factor where it's like, I just don't care. And I don't know about you being old. Mm-hmm. The older I get, the less I care about what people think. In my 20s, I was diagnosed at 26. I was very different in how I think about a lot of things. And today, go ahead, say what you need to say. I'm not going to worry about it. And I think that comes with age as well. So I think the folks who are diagnosed as teens, young adults, that's the biggest impact, because what life was like before. It's a very formative time of life. And I think think that's where that impact is going to be most significant.
Yeah. And I mean, if you think about that's the time when you really are forming who you are. You're doing some experimentation with, do you want to be goth? Do you want to be preppy? You're sort of figuring out how you want to present yourself to the world. And then you like layer in this chronic illness. And I can imagine that does make it even more difficult to say, I don't care what other people are thinking about me, or I'm not going to add that into this pot of trying to figure out who I am to the world. Huh.
For sure.
Interesting. What is your suggestion? Because what we're talking about, so many of these things like perceived, stigma and potential trauma and pathologizing things that feel normal to somebody with IBD are all potentially places that happen within that healthcare community. So as somebody who works with doctors and works in this big academic center, what could healthcare providers be doing to try to ameliorate some of this?
Yeah, I think the shortest answer is words matter.
Okay.
I think of one of the people I interviewed for the PTSD study who described a surgeon that he met with in the hospital who was very graphic in how he described this person's bowels, that they were icky and that they kind of disintegrated in his hands. And so he's like, you know what kind of nightmares I have? Because this is what's in my body. And I think the surgeon was just like, this is interesting. And, I'm just being helpful. I'm teaching this, or I'm letting this person know how sick he was and now he's better. I truly think that most medical people, physicians, nurses, whoever, aren't being malicious, aren't intending to be traumatizing. So this work is interesting because I'm like, hey, could you not? And I don't want them to feel like I'm pointing fingers. I'm not. I think we all say stupid stuff, right? So being mindful of what you're saying and then checking in, being like, how you doing? That was a lot that we just talked about. And this doesn't have to be in the hospital. This can be an outpatient visit, talking about new medication or something. I remember talking to my GI about picking 2 medications, and one of them has that brain thing that you can get. I won't go into, too much, but it's like, oh, that's cool. If you get that, that's it. Party's over. No more Triscuits. And I had to decide on the spot, that was stressful. So asking, even in a medication conversation, if the person, even if they don't look super stressed out, people with IBD are really stoic. We are good at hiding, right?
Yes.
Sometimes I'm like, I'm going to be real. I'm going to let my doctor know. And I just sit there like, yep.
Yes.
Nope, yep. Okay. Sounds good. And inside I'm like dying and screaming, but nope. Okay. Yeah, I can do that. Sounds good. It's dumb, and I'm sure there are people who don't do that, but I feel like talking to people with IBD over the years, a lot of people describe themselves in this kind of like pathological stoicism.
No, I think that you are absolutely right. I mean, I had my daughter on a doctor's visit with me and she's like, remember you're going to say this, Mom? And I was like, oh yes, I was going to say that. Thank goodness I brought you with me, because otherwise I would not have said that at all. It's just, I planned to say it. I told her ahead of time I was going to say it, and then I wasn't going to say it when I got in front of the doctor. So yeah, we do. I think a lot of us do that.
Yeah, we freeze, and some of that can be trauma related, right? There's fight or flight, and then there's freeze. And so if I'm feeling particularly stressed and kind of getting triggered by some of the conversation, one of the responses is to freeze. And so back to what medical folks can do, say, hey, how are you? And if the person isn't going to tell you, they're not going to tell you. So I'm not saying initiate a therapy session, but simply asking. So one of the things people said was, why didn't anybody ask how I was doing? Not how I was doing physically, but how I was doing with anxiety. That would have made all the difference in the world if somebody had just spent 5 minutes. I don't think most people are looking for a therapy session, but I think people who aren't trained in mental health, they get a little rotation, right? That's it. Don't feel comfortable. And so they avoid it. We avoid what feels uncomfortable. And I think a lot of physicians and nurses, not nurses as much, feel uncomfortable talking about our feelings. And they worry, they're busy, that they're going to turn it into some like hour-long conversation, which I don't really think happens as much as they are afraid might happen. And just doing those things means a lot and could mean the difference between someone developing PTSD and somebody not. That's how important words are, and asking and being human. Think about if you were sitting in that bed, take off your technical hat, right? And put on I'm sitting in this bed, being told X, Y, and Z. I might feel a little stressed. Or if this was my daughter or my son, or my wife or husband, try and personalize it a bit so that you feel like you can connect with them outside of the technical conversation that might be being had.
And I think the stress on using EMR and like putting your notes into EMR is also not helping any of this, because a lot of times doctors are like, typing and talking to you at the same time to try to do their notes, which makes sense. I mean, I get it. But even sometimes looking at somebody's face, you start to see them disengaging. You can see from their faces that they're starting to like think too much and you've lost them. And so how do you then go, okay, wait a second, like I've lost you, come back and talk to me about what's going on in your brain right now, because you're getting concerned about, a brain disorder, or I just said that your bowels are icky and that didn't sit well. Like what a stupid thing to say. Anyway.
Yeah, for
it's
sure.
hard to do that when you're on the computer.
The EMR is a big part of this, I think, and doctors are burned out. And this was going on before COVID, right? And now it's just shortages and staff resigning and turnover. I mean, it is a disaster in some places. And so I feel it. I feel them wanting to just put on autopilot and get the job done and fix the medical issue and the mental health well. Yeah. And I just really want to implore the importance of conversation and connection and how far that can go. And if you think about it in terms of preventing problems down the line, right? Somebody who's feeling super anxious or traumatized either is going to disappear on you and show up when stuff's really bad, or they're going to be sending you 15 messages a day because they're freaking out about what you talked about. And so you can mitigate a lot of that in a minute or two in a visit. And so I think looking at it even from those perspectives, not just from the patient's benefit, but from everybody's benefit.
For sure. Yeah, that is an interesting way to look at it, is that you're potentially making your life a little bit easier just by saying, hey, we're a team. Let's do this together.
Mm-hmm. I feel like this has been, I'm a big football fan, like sports. I love it. But I feel like this has been, Alicia has been the expert commentator and I'm the color commentator today because she's been asking all of these very insightful questions. And I'm like, yeah, well, when that happened to me, so I'm just here for color. I'm just here for color today.
I mean, how boring would this podcast be without color?
Yeah, you need color for sure.
Right. Otherwise, I just ask like dumb questions. So it's good. It's good. But I love that you were like, I really like football, right. Sports. Yes, Robin. Just because we live in the Midwest doesn't mean that we don't know what football is.
I'm sorry. The question that Alicia just asked actually does lead us into the final question that we usually ask everyone. In addition to what Alicia just asked, and you can go patient or professional or both to round out our talk today, what is the one piece of advice, one thing you want people to know, one thing that you would want to leave the IBD community with today?
I would say that all the stuff we talked about today, because we covered a lot of different things, they're all mixed together in like a big bowl of spaghetti, to go back to white food. Stigma affects eating is influenced by trauma, trauma is influenced by stigma, like it all kind of plays off of each other. So even though we talked about them in like distinct research categories, all this stuff is kind of going on in some form for most people. And so I think not letting stigma keep you from seeking help. So mental health is highly stigmatized. It's better than it was, but it's still really stigmatized. Don't let that keep you from either asking for help as a patient or talking about mental health with your patients and worrying about them feeling like you're stigmatizing them. And then once you recognize that maybe you have some PTSD symptoms going on, and then if you try some self-help and it's not working, really seek that mental health treatment that I know I said is difficult to find, but you can find it. It may take some effort. Like Josie said, I think she saw 3 or 4 people before she got the right fit. You can find really great people to work with to help you with the mental health side of IBD. And if you're a physician or someone who works with folks with IBD, build that trusted referral line, right? You got your other people that you like to send your patients to, your rheumatologists, your hematologists, all the ists. Get some psychologists some social workers. Social workers are just as qualified to do what I do. As long as we've had the training in health issues, chronic illness, the degree isn't what matters. It's the experience of folks who are living with chronic conditions. Build that so when you do talk to your patients about mental health, you don't sit there like, well, now what am I supposed to do? You feel like, okay, I got 5 people in my area that I know could probably get you in a reasonable amount of time. Let's figure out how to get you connected to them. That goes a long way. So that would be my advice for both.
That's such great advice. And yes, working with a psychologist is fantastic, but there's also licensed marital and family therapists. There's licensed professional counselors. There's social workers who specialize in clinical. And so there's people that do special training to specifically do therapy that are out there available to you. Tiffany, such a delight to have you. Thank you so much for joining us. We really appreciate you sharing both your personal and your professional perspective.
We really appreciate your time.